All right.
Good morning, web shadowers. We would like to thank you all for attending our session this morning. Today, we have the pleasure of hosting Dr. McKay, a dermatologist.
As always, please remember that the Google form will be posted in the comments and on our Instagram bio at the end. With that being said, Dr. McKay, you may start whenever you're ready.
Okay. Hi, everyone. Good morning. My name is Cather McKay. I'm a board certified dermatologist in Fort Walton Beach, Florida, which is on the Panhandle. And I'm excited to do this. I commend you guys for making this program and making this opportunity for other students to shadow or virtually shadow. I tried to make some cases that are realistic and representative of what I see in clinic. And so I'm excited to do this. Thanks for having me. Let's see, make sure, there we go. So I'm going to talk a little bit about what brought me to dermatology and, my path to get there. Some advice, very brief advice, but a little bit of advice for college and med school. An overview of what the field of dermatology is all about. A little just overview of my day, a brief anatomy of the skin, and then 2 skin cancer cases that I'll go into a little bit of depth on. And then if you guys have any questions, feel free to put them in the chat. All right, so I am from Mobile, Alabama. No doctors in my family, so I always knew I wanted to be a doctor. I did not know I wanted to be a dermatologist until I got to medical school and started rotating and experiencing the different specialties. Oh, sorry. It's okay. Sorry about that. So I grew up in Mobile, left for college, went to Vanderbilt. I had double majored in molecular and cellular biology and Spanish. So as a pre-med, all the pre-med prerequisites, they overlapped a lot with the biology major, and I just liked biology, so it took a few extra classes to make that a major. And then I really wanted to learn Spanish, so that was it was a nice balance of 2 different types of classes. I did research probably starting in my junior year, and just found some opportunities. One was through my sorority. There was someone who worked with our sorority had worked in the Department of Biomedical or Bioinformatics. And so I just really liked the professor there and did some projects with that. And that's kind of using technology in medicine. And then also did some basic science research in the Department of Biological Sciences. I didn't necessarily, I just looked for open opportunities and whatever worked with my schedule. So I think any experience that you have, it doesn't necessarily have to be, what your long-term goal is. Dermatology was not on my radar. So I just did things that I thought were interesting and that worked for my schedule. Of course, doing extracurricular activities, volunteer work, and I was pretty active in my sorority. And then all of that kind of goes into your application. So just having a little bit of each of those areas just helps make a good application for medical school. I knew I wanted to take some time between college and medical school. So I just stayed in Nashville at Vanderbilt and continued a little bit of those research projects for about 6 months. And then I spent 6 months in Guatemala. So if that's on your radar, something you might want to do, I highly recommend taking some time to do something life experience, get you some life experience, because there's really not a lot of time off after that period. So I really enjoyed that. And I kind of did my application process towards the end of my senior year, and a little bit during that year off is when I interviewed. So medical school, I went to UAB in Birmingham, Alabama. It's a state school for me because I'm from Alabama, but it's a really quality program. So I was fortunate in that regard. So of course, med school is 4 years. The first 2 years at most places are more like curriculum based, in the classroom and textbook, whatnot. And then the second 2 years are your clerkship years where you are in the hospital working with patients. I also did some research. So when I started med school, I thought I wanted to be a neurologist. And I found a good project in the Department of Neuroimmunology. And later on, when I realized maybe dermatology's for me, got in contact with that department and worked on a few projects. Volunteer work is there's a lot of opportunities in medical school to do like volunteer clinics and mentorship as well, even for like pre-med students at that time. So that was neat. And then, because again, during medical school, you're kind of working on your application for residency. So there's always kind of something next. So just being involved outside of school is still pretty important, especially if you want to go into a competitive specialty. So at the end of medical school, you match into your residency. And in dermatology, you do most programs, you do first in a year of what's called an internship. So that is for me, it was the Department of Internal Medicine at Tulane, and that was my intern year. It's called a preliminary medicine year. There's different programs. You can even do an internship in surgery or pediatrics. So there's, depending on your interest. And then after that, you go into your dermatology residency, and that's 3 years. Some programs are, it's all included together, so it just depends. But I did mine both at Tulane, but just in those two departments. And then after dermatology residency, you can do fellowships. So I just went into private practice, which the majority of people do go into general dermatology and don't do a fellowship, but I'll tell you a little bit about the fellowship opportunities there are after your residency. So when I was getting towards the end of my residency, then I was looking for jobs. So applying for jobs, and I've joined a private practice. So that is how I got to where I am. Briefly, a little bit of advice for college to start with. So just get this out of the way. There we go. So work hard. It goes without being said. Unfortunately, it's almost impossible to get through college, med school, residency without working hard. I mean, we're all hard workers, and that's part of it. So grades are probably you kind of have to have that as to get to the next step. So the MCAT, yes, that's important. Research, extracurriculars, and having mentorship and letters of recommendation, that's all important. But grades probably are, I would think, the most important, because there's going to be certain cutoffs and whatnot that you can't even get your application reviewed if you don't have the grades for it, for the most part. Establish your study method. So there's a lot of memorizing in medical school and even in residency as well for dermatology. So it took me 4 years of college to figure out how I learned the best. So it's a lot of trial and error. Like, you study one way, you don't do well on that test. Well, maybe that's not the way that I need to study to learn the best. So you kind of switch it up, figure out what works for you, because it is, I think everybody's different. Some people can listen and learn that way. For me, it's like writing and rewriting, and that's how I memorize. So anyways, figuring that out during college will help you a lot later on. If you can, figure that out, you'll be ahead of the game when you start medical school. And then learning to take care of yourself. So that this sounds, there's a lot of burnout in medicine. And so establishing ways early on that help you cope with the stress, everything that school and all the extra stuff you have to do that's stressful, and finding ways that, whether it be exercising or having solid relationships, all that's going to be important. And if you kind of start working on that and thinking about that in college, it'll help you later on. I put on there, forgive yourself, because a lot of people go into medicine are very type A, very hard on themselves. So I failed an organic chemistry test and was absolutely devastated, but it happens, you move on. I still got to where I wanted to go. So if stuff like that happens, it probably will. Something, everything's not going to go exactly perfectly. So forgiving yourself, establishing self-care habits, also, those are great. And then of course, wear sunscreen. I had to put that in there as a dermatologist. Start early. You'll be grateful later. And then med school. So the way that I approached college, I was like, oh, I'll figure it out later. Like my junior and senior year, I was like working to get my GPA up, because my freshman and sophomore year, I was like, maybe had a little bit too much fun, or who knows, but med school, it really gets away from you and it goes by so quickly. And so if you go in thinking like, I'm gonna study hard from day one, like I can't like wait until the next test to do well. Like I think that's a really good approach, especially if you don't know what you want to do. Just doing still putting in the work as if you were going to go into something very competitive helps. That way, if you come back around like your third and fourth year and you're like, well, maybe I want to go into plastic surgery or orthopedics or anesthesia, some of the more competitive specialties, you have that foundation from your first 3 years. So I think that's a good philosophy. So in medical school, you do get grades at some places. Some schools are pass fail. Some schools give you a percentile. So it's a little bit different, but you still get, kind of ranked in your class. So it's still important. The grades are at most places still important. Step exams, those are, I don't know if anybody else has talked to you about those. They are national exams. One is at the end of your second year, so that's called step 1. And then step 2 is in your end of your third year, fourth, and then and into your fourth year. And then step 3 is an exam you take after you've graduated med school, so sometime during or at the end of your intern year. So those are exams that you have to pass in order to eventually be licensed in medicine. And the first step 1 and step 2, because you get your grades back before you apply for residency, they can be used as, you kind of part of your application and make you more competitive for certain residency programs or specialties. They might be changing the way they grade step 1. So that might be different from when I was in medical school, but these are not things you need to worry about now, but just to give you a little, give you some of the lingo. Because I had nobody in my life that was in medicine, this was all like a foreign language to me. I did not really understand the whole process and what everything, what med school was all about. So just to give you like a little briefer. And then research and extracurriculars, and finding mentors that you get along with, that you can have a good relationship with, and that later can write you a letter of recommendation. And research is a really good way to get that relationship, because you work closely with, a professor or a physician. Picking your specialty, so stay open-minded. Like I said, I started thinking I was going into neurology, and then completely changed course. So that happens. It happens all the time. So just when you're getting, I think this is a great idea, just getting a little overview of different specialties through this web shadowers is awesome. And then once you get into med school, you'll get experience with different fields. And then continue to take care of yourself. That's always important. So, all right. Overview of dermatology. So what is a dermatologist? A dermatologist is a doctor who specializes in conditions involving the skin, hair, nails, and mucous membranes. And a dermatologist can identify and treat more than 3,000 conditions. And we treat patients of all ages, so newborn babies all the way to senior adults. So there's a lot of variety in dermatology, which I love. So a lot of our, we treat skin cancers, we treat inflammatory skin conditions, so rashes, eczema, psoriasis, a lot of autoimmune conditions, infectious skin conditions as well, so bacterial or viral infections of the skin or nails, genetic skin conditions, so there's a whole lot of things that you can inherit that cause skin issues or conditions. So we learn about all of that and are able to treat those. And then there's also cosmetic conditions that we treat as well. So what does it mean to be board certified? So there's a big campaign to educate our patients about, finding someone who is board certified is the best. You can guarantee that they have the best training and have been through. So what that means is complete medical school, internship, and residency at an approved program or accredited program, a license to practice medicine. So for me, that's in Florida. So each state, you're licensed in your state. And then you've passed the exam given by the American Board of Dermatology, the Osteopathic Board, or the Royal College of Physicians and Surgeons of Canada. So there's a big exam at the end of residency that you take to be board certified. And then there's some certain requirements throughout your career that you have to maintain, like maintenance of certification, education, plus every 10 years taking another exam. So it's a lifelong thing. What types of dermatologists are there? So for me, I'm a general dermatologist, and the majority of residency graduates go into general dermatology. So we do a little bit of everything, but you can get a fellowship after residency. So there's pediatric dermatology fellowships, and usually pediatric dermatologists are at academic centers is the most common place to. There's not that many. Usually, there's a few probably in each state at the most, and they're usually at academic centers. A cosmetic dermatologist. So there are fellowships to go, to learn more about lasers or cosmetics, and but you can also just focus on cosmetics if you want that to be your practice. You don't necessarily have to do a fellowship, but those can be very helpful. Dermatopathology. So that's when you look at biopsy specimens under the microscope. So you train in dermatology, and you do another year where you specialize in dermatopathology, and you can have both clinic patients and then spend time looking at a microscope at reading skin specimens. Pathologists, so you can also do a residency in pathology and then specialize in dermatopathology so that you're only looking at skin in your career. And then Mohs surgery, I'm going to talk a little bit about that, what that is, but that is a specialized type of skin surgery for skin cancers, usually on the face or kind of cosmetically sensitive areas. And I'll talk about what that means, but that's a popular fellowship. So this is an estimate. I think the numbers kind of change, but as you can see, the majority, when I say general, it's kind of like medical is another word for that, but medical dermatologist. So most people do that. Non-cosmetic surgical, so that would be the Mohs surgeons, and then cosmetic fellowships. So it's a little bit of the breakdown. And then there are some very unique specialists at usually at academic centers that specialize in certain types of cutaneous lymphoma, immunodermatology. So there are, within medical dermatology, there are some kind of super specialists who everybody would send their complicated patients to, for a referral. All right, so a day in my life. This is my office. I usually get to work at 7 a.m. My first patient is not until 8, but I kind of spend that first hour just kind of getting settled and kind of catching up on any tasks that I didn't get to the day before. Then we technically have a break for lunch from 12 to 1, but usually, oftentimes the morning clinic or the morning, I do a procedure before lunch in case it runs into my lunchtime. That's fine. It doesn't push me back for the afternoon. So sometimes I get a full hour, but oftentimes not. And then my last patient around 4 or so. And then if I do get any downtime during the day, there's a lot to do after you see a patient. So calling back with the results or just signing off on results. And sometimes the nurse will call the patient to say, oh, this was benign, or, but there's a lot of things to follow up. So there's always stuff to do during any downtime, answering staff messages, signing notes. Of course, we do a lot of charting and whatnot. So I try not to do anything at home, but sometimes I have to finish up notes or whatnot at home, but I try to do it all before I leave. So there's a lot of variety in each clinic day. And so let's see, I'll have a mix of new patients and follow-ups. I'll have usually 2 surgical excisions a day. And then sometimes there'll be some cosmetic procedures sprinkled in, like Botox or filler or whatnot. But majority of my patients are medical. So skin checks, acne, warts. That's kind of the next point, is that there's a lot of variety. So you're seeing possible skin cancers, acne, psoriasis, eczema, rashes. And then the typical general dermatologist, like in private practice, will have a sprinkling of complicated skin conditions. Some people, that's all they see. So it just, you kind of make it what you want. And then a variety of procedures as well. So I'll talk to you a little bit about skin biopsies, cryotherapy, electrodesiccation, excisions. So sometimes during a clinic visit, if you see something that needs to be removed or biopsied, so we're doing that throughout the day. So there's kind of a lot of different stuff going on, which I love. No 2 patients are the same, and no 2 days are the same. Okay, so the fun stuff. So this is a very basic anatomy of the skin. So we have the kind of 3 main regions. So you have the epidermis, the dermis, and the subcutis. So within the epidermis, they blow it up here. There are 3 main types of cells. So you have squamous cells, melanocytes, which make pigment, and then basal cells. So the basal layer is, a lot of these cells are replicating. And so as they mature, they turn into, mature into squamous cells, and then they basically die and, give this top layer called the stratum corneum. This is the outermost layer, and then that sloughs off. So it's kind of a continuous process. It's very active. And then down in the dermis, you have your blood vessels, collagen, hair follicles go down. And then in the fat, you have more blood vessels. And yeah, so what I'm going to focus on today is skin cancers. So skin cancers are named after the cells that they derived from. So squamous cells, you can get a squamous cell carcinoma. So that's just a type of skin cancer. Basal cells, you can get a basal cell carcinoma that starts from the basal cell that has just kind of gone haywire and started reproducing and causing a tumor. And then melanocytes give rise to melanoma. All right, so try to make this like what I experience each day. So I have nurses that check in the patient, talk to them about why they're there, review their history, and update their medication list and all that. So all that's done before the nurse comes to me and says, I have a patient ready. So then a lot of medicine you'll learn throughout medical school is about communication. So everything is kind of regimented. There's a certain way to describe a patient, to even the way we communicate about a patient to another doctor, or the way that it's charted in the medical record. All of that is very, there's a reason and a format for that, which you'll learn throughout your training. So she may say something like, Mr. Jones is a 68-year-old Caucasian male. He's a new patient with a history of basal cell carcinoma on the right cheek in 2013. It was treated with Mohs, and he's here for a skin check. He has a spot on his nose that has been slowly growing for the last year that is now bleeding on his pillow. So breaking that down a little bit. So there's a lot of things going through your head when you hear a patient presented to you. So you already are kind of formulating like what could be going on. So he's 68. So that means, he's been around, his skin has seen probably a lot of sun over the years. And he's Caucasian, so fairer skin, more likely to have the, sun damage and higher risk of skin cancer. He's had a basal cell already, so that in of itself, makes you at risk, because if you already had one, that's a good indicator that you have some risk factors and you could have another one. And then, so he's here for a skin check, but he's had a spot that has been growing for a year. So things that grow over time usually, catch our attention. Not always bad, but that should catch your attention. Like, we need to focus on that. So you look over his medical history, his medications, his allergies, and then you go ahead and you talk about it further with him. So this is called the history of present illness, the HPI. So whatever a patient is concerned about is important. So the reason they're there. And, you'll see, no matter the specialty, patients tell you a lot. They're in their body every day. They know when something is not right. So always listening to making sure you address their concern, even if it's, ends up being fine, it's still their concern, so it needs to be addressed. And there's a lot of people who say, like, you can basically talk to a patient, and sometimes, the exam is of course very important, but a patient could describe to you what's going on, and usually you can have a good idea of what it is. So growing for a year, red, tender, and now bleeding on his pillow. So that prompted him to come in when, things like that happen. That's not normal behavior for a normal skin lesion. So so other details, as you're talking to him, you realize he grew up on a farm, which a lot of times that means a lot of sun exposure, a lot of time outside, a history of sunburns, doesn't wear sunscreen, which is not uncommon for people of that generation that really didn't have sunscreen for a long time, or easy access to it. And then he has many other scaly spots on the face and trunk, but nothing else really bothering him. So when you do your physical exam, so in our clinic, it's typically a focused exam, meaning just we kind of see what they look like, and then do an extensive skin exam. In other specialties, you may listen to heart, lungs, do an abdominal exam, a joint exam, and we do some of those depending on the patient, but for the most part, we're doing a focused skin exam. And for me, a full body skin exam, start at the scalp and work my way down, go all the way to the toes. So lots of ground to cover. So when you start looking at him, this is what he has come in for, really. So this is his spot of concern. And in dermatology, there is a lot of the way you describe things is important. So you learn this throughout residency, starting in med school and then in residency, you really learn how to accurately describe things, because that is, a lot of how it gives you alarm bells of what that is when you have a certain morphology, or when you're communicating to somebody else, then they can understand what you're talking about. Okay, so I'm going to see if the chat thing works. So does anybody know what this could be? I heard there was a delay on like chat. I just want to make sure. Does anybody have any thoughts? Someone said melanoma. Good thought. Squamous cell, so SCC, squamous cell carcinoma, also a good thought. Basal cell carcinoma, eczema. So good. So this is what's called a differential diagnosis, when you're kind of thinking, this is what I think it could be. So that's called your differential diagnosis, meaning you're not sure, but you have your thoughts. So the way that the way that this is described is a pearly pink papule. So pearly pink, it kind of has that translucent look to it. Papule just means it's a bump, less than a centimeter. Rolled borders, so the edges are kind of rolled up. And then telangiectasias means it has prominent blood vessels. And that's why these often bleed, because those blood vessels get enlarged and then can ulcerate and then cause some bleeding. So those are all great thoughts. My differential would be for a basal cell. It very well could be a lot of those other things. It's really up to the pathologist. So pathology would tell us exactly what it is, and therefore we would then know how to treat it. So the plan would be to biopsy it to confirm the diagnosis. And then someone asked, can you visually identify what type of cell it is from? No, not. So under the microscope, you would see what types of cells make up the skin lesion. So for this one, I would, I'm going to show you an example, but, and then is this described the same for people with darker skin? Well, it would depend what exactly it looked like, but if it looked like this, even on darker skin types, it would still be described the same way. All right, let's see. There we go. So we're going to come back to that in a second, what we're going to do about that. But as you continue your exam, this is what you'll see on the patient's hands. So I would describe these spots as scaly. So you can see that white scale on there. Scaling, erythematous, so they're pinkish. Papules, so they're raised. And then non-scaling, so totally flat, brown macules. So a macule is just totally flat, you can't feel it. So you have both of those things happening on his hands. Any thoughts on what this is, or why his hands might look like this? Y'all are doing great. I'm excited about that y'all are participating, so thank you. And then just to go back, basal, okay, there we go. Sunspots, yeah, perfect. So the brown spots are definitely, the layman's term is sunspot. The medical term for that type of sunspot is called a lentigo, or lentigenes is the plural. So sun damage, absolutely. Yep. And SCC and sunspots. So that's a really good thought. So what this is, sun damage over the years. Perfect. Y'all are great. Actinic keratosis, how'd y'all know that? Okay, so yes, these scaly spots, kind of these rough pink spots, are called actinic keratoses. And this, the way I explain it to a patient is an accumulation of sun damage over time, and it eventually kind of shows itself as these spots. We do consider them precancerous. So the person who guessed SCC, great thought, because these can turn into an SCC, a squamous cell carcinoma. So we're always kind of thinking about that. If it's gotten too big or too raised, could it be actually a skin cancer? But for the most part, these look like precancers, which are called actinic keratoses. Actinic means sun, so derived from the word for sun, and then keratoses are just raised spots or growths, really. And then lentigenes are the brown spots. So all together, yes, you would call this sun damage, or another way to say that is solar elastosis or actinic elastosis. So a lot of people who are fair complected, who've had a lot of sun exposure, have skin that can look similar to this. So what do we do? Our plan for this, because like I mentioned, these spots can be precancerous. They could turn into a skin cancer. We freeze those, and that is called cryotherapy. It's liquid nitrogen, and I'll show you a picture of what that looks like later, but we do treat those. But the brown spots, those are sunspots, those are not harmful in and of themselves. So we reassure that there's really nothing that needs to be done about those to treat them right now. And then you get to his back, and he has this. So these scattered brown and tan stuck on, meaning it might be hard to appreciate that in a picture, but in person, these look stuck on, meaning it looks like you could almost scrape it off, but you can't. So that's the way these are classically described. Does anybody know what these are called? Give y'all a minute. This is kind of a hard, specific question, but melanoma. Okay, good thought. Freckles, moles. Skin tags. These are all really good thoughts. SK. Oh, yeah. Okay, so good job, whoever knows what that is. These are super common, but patients come in all the time saying, what is this? Like it, there's almost on everybody, if, at some point. And these are called seborrheic keratoses, and they are completely benign. You would kind of look closely to make sure there's nothing abnormal, in between these, but for the most part, all of these are benign spots. They bother the stink out of patients. We can freeze them if they're bothering them, but they're not harmful. They're not dangerous. They don't turn into anything. So we just usually say, don't worry about it. So these are super common. Okay, so to summarize what we've seen on his physical exam, the very first thing was that spot on the nose. And in dermatology, when we don't know when we're going to biopsy something and we don't have the diagnosis necessarily because we need to wait on the pathology results, we call it a neoplasm of uncertain behavior. And that's just, it's a neoplasm, so it's a growth, but we're not sure what it is. So we leave it called that until we get the results back. And that was on his right nasal bridge, and we're going to do a shave biopsy for that. So I'm going to tell you about that. I'll go ahead and tell you about that. So this is a picture on the right of what a shave biopsy might look like. We do that in clinic, like same day. So they're there for their skin check. If we see something that needs to be biopsied, this doesn't actually take very long. So we numb it up. use lidocaine, so a little injection of lidocaine. It's goes numb quickly, and then we use different tools, and this is one example of a type of blade that might be used to get a sample of it. So we take off the sample, stop the bleeding, and put a Band-Aid on it, put this in a specimen container with formalin, and then it gets transported to the pathologist if they're at a different location, then processed, put on a slide, and looked at under the microscope. So this spot would need to be biopsied. The actinic keratoses on the hands, those pink scaling spots, would be treated with something called cryotherapy, which usually looks like a canister like this that has liquid nitrogen in it. So you spray that, and it's very cold, like negative 198 degrees Celsius, I think. So it's cold, it completely just destroys that, whatever you spray it on. So we use that for a lot of things, precancers, warts, things that we just want to kill and have them fall off. So that's what we would do for his hands, or for the precancerous spots. The lentiginous, so the sunspots on his hands, we would just say, don't worry about those. And the seborrheic keratoses on the back, we would also say, don't worry about those. So we would document all of this similar to this, and that's our assessment. That's what that's our interpretation of everything. And then our plan is, what are we going to do about it? So patient leaves. After the visit, it'll take usually a few days to get his results back. So during those few days, that specimen is being sent to the pathologist. They have a lab where they process it, they stain the tissue. It's called, they start with something called H&E, hematoxylin and eosin, and it gives, in skin, it gives this classic, like, characteristic color pattern where you have pinks and purples and sometimes blues. And so that this is something we learn in dermatology residency as well, as like what things look like under the microscope. But most dermatologists aren't reading their own pathology, so it's not something that we have to do usually. But the dermatopathologist does it all the time, all day, and they look at it, give us their interpretation. So this is what a basal cell carcinoma would look like under the microscope. So this is probably too much information, but this is your epidermis. So you have your stratum corneum. These are your squamous cells. And these are your basal cells, so your basal layer all along the bottom of that epidermis. And then all this pink stuff is your dermis. But these big round nests of cells are not normal. So that's where our pathology is. And when you look at this, it has certain features that suggest it's a basal cell skin cancer, because these cells are darkish, so we call that basaloid. And then there's certain features that they're all lining up along the edges like a normal basal cell would try to behave, but it's kind of growing out of control, so it's making these big nests of tumor cells. So when you get that back, it would say, basal cell carcinoma, and there's subtypes that it would tell you, but and it would give you a description as well. But you just, you see, oh, it's a basal cell. So on his nose. So what I need to do about that is, and then now I'm going to kind of tell you more about Mohs surgery. So when skin cancers, especially that one was a pretty sizable skin cancer, pretty big, on places like the nose, there's not a lot of laxity and skin around there to just cut it out and stitch it back up. It would distort his nose. He would be disfigured from that. So the specialist, it's a dermatologist that has an extra training in Mohs surgery, would see the patient. So we would refer the patient to see a Mohs surgeon. And some dermatologists do both, see the patient, and then they are trained in Mohs surgery, so they just schedule them an appointment for Mohs. So in Mohs, the word is actually the doctor's last name who invented Mohs surgery. So that's kind of a confusing name, but it's named after the doctor who invented this procedure. So what you do is step 1 is the visible tumor and a small segment of surrounding skin is removed. So they numb up the patient with lidocaine, remove the tumor and just a little bit around it. That same day, so the patient's still in the clinic, they put a bandage on, let them hang out, and they have a lab in their clinic that processes the tissue. They freeze the tissue so it can be analyzed quickly, and they stain it. And then the same person who cut it out is also the pathologist, who then looks under the microscope to look at all of the edges. So the way that they put the tissue on the slide allows you to see all the edges and all the bottom, if you think of it kind of like a bowl. So they're able to look and see, is there any positive margin? And as you can see in this first picture, this base of the tumor is still there. So they would be able to tell on the microscope that this margin is positive, meaning there's still some skin cancer on that patient. So then they go back to the patient, unbandage it, take a little bit more. So in this case, they could tell under the microscope that it's the base of the lesion where the skin cancer is still present. So then they go back and this is called another layer of the tumor. So they take just around that. So then additional skin continues to be removed and examined under the microscope. So sometimes they get it on the first try and the whole thing is out, the margins are clear, and then they're done, or then they stitch them back up. But sometimes they have to go back in and remove little bits more until the whole thing is out. And sometimes it takes, if they're sneaky and they're growing in different directions underneath the skin, they can go and microscopically determine where they need to take more skin until it's clear. So the way that this is what's unique about it, is the way that the skin is processed and examined, and then it gives you at least a 98% cure rate. So it's really high. And then, so this is an example. So the Mohs surgeon would do the procedure until the whole tumor is gone. And then usually the Mohs surgeon is also the reconstructive surgeon. So they're closing this. So they have to get creative and figure out, well, how I can't just pull the sides together because his whole nose would turn up. And it would be bad and, impair his breathing. And so you have to get creative and figure out, how am I going to close this that leaves the nose looking nice and working like it should? So this person did a flap where you take skin from this area and pull it down and cover the defect. So this is a pretty, it's very creative, and they do a great job. And as you can see, like much later, the scar looks great. So most surgeons do really awesome work. So this is kind of where this case would end. And then the patient would, after he's all healed, I would say usually 3 months later, they would come back and get another skin check and make sure they hadn't grown anything else. So usually after the Mohs is completed, that skin cancer is treated. There are a lot of other ways to treat skin cancers depending on where they happen. So sometimes I, as a general dermatologist, excise skin cancers, especially if they're on the body or smaller. If there are certain low risk subtypes or very superficial, then they'll do creams, or there's certain procedures where you can kind of scrape away skin cancers. Anyways, you learn all that, like what's appropriate, what's indicated for certain types of skin cancers, certain sizes, certain locations. So it all depends on the specific patient and the specific type of skin cancer. So that is Mr. Jones. So as you can see, that 10-minute, 15-minute visit, a lot goes into that, and a lot goes afterwards too. So there's a lot of follow-up, and but as you learn all this is and get in the routine, you know, you're doing this all day long. So that's it for that patient. All right, next patient. And this is the only other patient. I just did 2 cases, so this is the second and last case. Okay, so you might have another nurse as the patient in room 1 is getting dressed and ready to go. You just go next door to room 2, and another nurse has this patient ready for you to see. So Mrs. Smith, so your nurse presents to you. Mrs. Smith is a 57-year-old African-American, new patient, no history of skin cancer, and she is here for a dark spot on the bottom of her foot that her pedicurist pointed out to her last week. So you review, we'll just a little bit more thoughts on this. So she's 57, African-American. So in terms of skin cancer, there are different risks depending on skin type. So fair-skinned people have minimal protection from UV, so higher risk for skin cancer. Darker skinned, so we call it Fitzpatrick type. So there's certain skin types depending on how much melanin you have in your skin. So melanin is sun protection. So darker skin types have more natural sun protection than lighter skin types. So that basal cell in that first patient, also squamous cell, they're less common in darker skin types, but they're not impossible. You can still get them, but it's just less common. So new patient, no history of skin cancer. So she has a dark spot on the bottom of her foot. And when she was getting her toenails done, they pointed it out to her. So that kind of gives you a clue, like must not be bothering her if someone else had to tell her it was there. So you look over her medical history, her medications, allergies, and you go in to meet her. Okay, so you discuss further with her as well. Like you say, I heard you're here for this spot. Tell me more about it. Again, that's called the history of present illness. So she noticed it last week. So therefore, she's really not able to tell you how long it had been there. She hadn't noticed it before. And it's completely asymptomatic. So it doesn't hurt, doesn't bleed. So she really can't tell you much else about it. You just review some other details with her. So no personal history and no family history of skin cancer. She's otherwise healthy and really has no other issues. So you go in for the exam. And when you see this, well, first of all, for the exam, you get a general sense of the patient's, how they appear, if they appear healthy or well, or they understand what you're talking about. You do her skin exam. And for this patient, I kind of am a little ahead of myself. I would do a lymph node exam. Let me see what's next. Sorry. So I'm going to come back to that because I'm going to tell you why we would do a lymph node exam, but not yet. Sorry. Yes, okay. I didn't put a little question of like, what are your thoughts? But I can already see on the chat that some are saying it's a melanoma. And yes, so the suspicion for melanoma for this would be very high. So it's irregular, it's brown and black, and that's not a normal appearing mole. You know, there's a lot to this. So melanoma would be on the top of my differential diagnosis, my list of possibilities. And then someone asked, are they diabetic? That's a great question. So we can say no for just the sake of conversation, but diabetes is a good thought for foot problems because with diabetes, you have decreased sensation. So you can get infections or sores on your foot and not know it. So that's a great question to ask. Fungal infection, excellent thought, actually. There is a type of fungus that can look like this on the skin. Keloids, hematoma, excellent thought. So blood trauma, when it's in the skin, can turn can turn dark. So as it oxidizes, that hemoglobin oxidizes, it goes from red to, and then it can turn dark and look like that. So those are awesome. That's called your differential diagnosis. Like, what could this be? And then I see that many say melanoma. So that's kind of where we're heading with this one. And then when you do see that that you're concerned about a melanoma, during that exam, you would start to feel for lymph nodes. So with melanoma, it's a more aggressive skin cancer, of course, than basal cell and squamous cell. So when you see one, you do want to feel, when you see one that could be a melanoma, when you're planning to biopsy, you do want to feel for any lymph nodes to see if at baseline, do they have any palpable or enlarged lymph nodes. And then I see on the chat, someone said talon noir, which is incredible. Yes, that is the name, the formal name for when you get blood underneath, like you traumatize the foot, it bleeds. And because that stratum corneum, that dead layer of skin is so thick, it can stay dark for a long time from the blood being there. So awesome, y'all are great. Okay. But she's there, you're gonna still do a full exam, especially when you see that. So, and she's like, oh, what about these spots on my face? Are they okay? So you see numerous brown and black stuck on appearing papules. So does anybody know what these are called? They have a very fancy name. I would not expect you to know the formal name for them. Keloids on face. Good thought. Go ahead and the fancy name, skin tags. So skin tags can look very, very similar to this. So the fancy name for this is dermatosis papulosa nigra. Very common, just kind of a genetic benign growth that can happen usually in this eye cheek area, more common on African American skin. So this, you can tell her, well, you don't need to worry about those. Okay, so to summarize, on your exam, you saw, of course, that neoplasm of uncertain behavior. So you're not, you need to confirm the diagnosis. So for this one, when you're concerned about a melanoma, the usual appropriate thing to do is to get the whole thing out so that the whole thing can be analyzed under the microscope. That's a little bit hard on the foot, so we won't go into all the nuances of that, but you could consider doing an excisional biopsy, which means you numb it up with lidocaine and cut the whole thing out, rather than if you think you could do a shave, like in the first case, a shave and remove the whole thing, then you could do that. But if you're not sure the depth and you need to know you need to get the whole thing out, you would do an excisional biopsy. So it's just another type of biopsy. And then on the face, the DPNs, the dermatosis papulosa nigra, you just reassure on that. Okay, so now you're sending that specimen that you removed. So you say you did an excisional biopsy, send it to the pathologist. They, again, are going to look under the microscope and see and tell you what they see. So unfortunately, this is a type of melanoma, and it's called acral lentiginous melanoma. So there are certain subtypes of melanoma, and African Americans have a higher risk. It's still very rare, fortunately, but it is a higher risk of having an acral lentiginous. Acral means like hands and feet, so the skin of the hands and the feet. Lentiginous means it grows along the epidermis. So this is the way that it grows. And melanoma, meaning it's a skin cancer derived from melanocytes. So when you look at this, this is actually a acral lentiginous melanoma, but you see the thick stratum corneum. So that's all the dead layer. So on the feet and the hands, it's very thick. So that's all that. And then you get to the rest of your epidermis. Your keratinocytes are this purplish color. You have your basal layer of skin cells, but all of this kind of lighter purple is a abnormal appearing melanocytes. So you can get clusters of melanocytes in moles, in regular benign moles, but when they start to grow in certain ways that the pathologist can see under the microscope and the cells themselves become atypical appearing, then you get more into atypical mole or melanoma, like in this case. So it's very much a pathologic diagnosis, meaning you need the pathologist to confirm it. There's a lot of nuances to understanding melanoma and how to treat it, but I'll try to kind of give you an overview of for this case. The most important feature is how deep it is. So they actually measure how deep it goes from the top of the epidermis to how deep it goes into the dermis. And we're talking on the order of, often it can be less than a millimeter. It can be, so a millimeter is teeny tiny, like, you know, so thin. So we're talking such little numbers. But once you get to a certain depth, you start to be worried, could this have spread already? So in certain situations, you get a lymph node biopsy at the same time that you would remove the melanoma. So hers is 1.1 millimeters deep. So this qualifies for a lymph node biopsy. So we'll talk about what that means. On the pathology report, it'll be a long description of everything they see, all the features that they see about the cells, and they'll tell you a few other things, like, is it ulcerated, meaning has it taken off, is some of the epidermis missing? So for her, no. Are there mitoses, which when you look under the microscope and you see cells dividing, you can see mitotic figures, and that is just a sign that the skin cancer is very active. So it's dividing, the cells are dividing. So these are you kind of risk stratify based on some of these features, and it helps you determine how to proceed, you know, what she needs done. So for her, for this case, I would refer it to a surgical oncologist. So she needs an excision, a wide local excision. And so on the foot, you can imagine that's pretty difficult, but you know, this is thing, you know, what they handle. So excise, make sure the whole melanoma is out with good margins. And a sentinel lymph node biopsy. So for certain types of cancer, and melanoma is one of them, you test the lymph nodes that are near the area of the cancer. So sentinel lymph node, it's the lymph node that drains that area. So as lymphatic fluid drains from a certain area, if cancer cells are trying to spread, then they can be found sometimes in the lymphatic system with the lymph nodes. So they often use like a dye that they inject around the area. So for her, it would be in the foot. And she would be in, you know, this would be the same time that you were removing the melanoma. And then you can test lymph nodes along the chain, either the popliteal, so behind the knee, or the inguinal would drain that area. So you test those to see, like, oh, has the melanoma gotten into the lymph nodes? In which case, if for her, let's say it was negative. So if her lymph node biopsy is negative, she still needs very close follow-up, and we would still feel her lymph nodes and see her and look at her skin every 3 months. And then if say her lymph node exam was positive, that's more serious, increases the stage of the melanoma, and means that she would be a candidate to get things like immunotherapies and or possibly chemotherapies. But there's a lot of treatments now for melanoma. So a medical oncologist would be on board to recommend treatment options. So she would have a big old team of people to manage her case. She would still see her dermatologist. She would still follow with the surgical oncologist, the medical oncologist. There's a lot with this diagnosis. Okay, so that is the end of that case. I do see a question saying, could you use tyrosinase inhibitors to reduce the pigmentation from sunspots on Mr. Jones's hands? Yes. So tyrosinase inhibitors, there's a lot of topical ingredients, like hydroquinone is one of them, and then some botanical ingredients that we use to decrease pigmentation. So possibly if it's really just for cosmetic purposes, we also use lasers and light-based treatments to target pigment. So there are cosmetic options if that patient was interested, for sure. Okay, I'm getting close. I think this might be the end. Advice. I thought I came up with this, but then my husband said that's a saying. So remember your why. So medicine is a difficult field. You know, it's difficult. It's a long road, many years. But you know, it's a lot of people do drop out, give up, and decide it's not for them, and that's okay. But the people, if you want to stick to it, and this is what you want to do, it helps to remember why you're doing what you do. When you start to get to see patients, that is like the best, so you really, it's incredibly fulfilling, and you get to easily remember why you do what you do every day. But when you're on the road there, like having to study, stay up late, all-nighters, all that, it's a lot, but it's doable. People do it all the time. You can do it, and just helps to remember like why you want to do what you want to do. So inspirational. Okay, so I just got a lot of my photos off of Google. And yeah, so that is a little over an hour. So thank y'all so much. Lots of neat interaction on the chat. So I'm grateful for that. And thank you for watching this. If you ever have any questions, I have a professional account on Instagram. So just message me. I check those and try to respond, quickly. So just feel free. So Cather McKay MD on Instagram, and I post a lot of educational stuff. And yeah. So anything else? Any other questions or anything?
Thank you so much, Dr. McKay. This was a wonderful and very interesting presentation.
Awesome. Thank you.
We all appreciate you so much.
Oh, absolutely. I'm glad to be here. I'll be back at the end of the month, and I'm going to do more like inflammatory conditions. So this was skin cancer, and then next time I'll do like psoriasis and eczema. And so just get another aspect of different types of patients you might see. So
that's wonderful. We can't wait. Everyone, make sure you check her out on her socials. Her Instagram is at Cather McKay MD.
We want to remind all of you that tonight the monthly roundup for September will begin at 11:59 p.m. EST, and it will close 11:59 p.m. EST on Sunday. So more information will be posted about this on our Instagram, including a document with every single link on it.
Yes, and remember that this is completely optional and just a way to allow you guys to get more hours. Please do not refill the forms that you have previously submitted before.
Again, thank you so much, Dr. McKay. We loved you, and we're really looking forward to having you again. And thank you all for attending as well. The link to the Google form is now posted in the comments. So please remember, you have to fill it out within 30 minutes for us to receive verification today.
Thank you again, Dr. McKay.
Very welcome. Thank y'all.
Thank you. It was a pleasure.
Y'all have a good day.
You too.